Good morning and welcome to the 4th Annual Aging Summit that Grace Center for Adult Day Services is again hosting as a service to this community. The focus of today's webinar is on the issues that impact individuals as they age. In addition, we'll be providing resources and information that will help in addressing these issues. But first, I'd like to introduce myself. I'm Marilyn Brazier, the current president of the board of Grace Center. I've had the honor of being involved with Grace Center ever since I first moved to Corvallis 10 years ago. My involvement with Grace Center actually first came when we had taken in my father, who was no longer to live on his own. In searching for resources that might exist in Corvallis to help us with his care, I had the good fortune to discover the Grace Center. By sending him to the Grace Center a few days a week, my father had an opportunity to participate in the many activities and services that Grace Center provides, and my husband and I were able to obtain some much needed respite from the demands of being caregivers. So later in time, a few years later, when a need came up for a new member on the board of directors, I was happy to volunteer and get the opportunity to give back to the organization. As a member of the board of directors, I and the other board members are able to not only provide an oversight function to the Grace Center, but also to assist in hosting the various events like today's Aging Summit that the Grace Center brings to the community. So today it's going to be my pleasure to be able to introduce our speakers and panelists. And some of the topics that they'll be covering today are, first of all, the impact of loneliness on the health of older adults and care planning for end of life, including a discussion on how the costs of the different types of care might be paid for. We will also have a panel presentation on important considerations for those who are planning to age in place in their home, and the resources that are available to put those plans into place. So each of our speakers will be able to answer questions at different times during their presentation. At the bottom of your screen, you will see a button that shows you a Q&A tab. At any time during the presentation, you can click on this tab and type in your question. Your question will then be forwarded to the presenter to answer. They'll either be during or at the end of their presentation. So now to begin with our presentation, I would like to introduce Denise Ratana Paibon Charan, the outreach coordinator for the Grace Center. Denise has been working tirelessly to help put together this webinar today. So here is Denise. Please welcome her.
Thank you, Marilyn. Just to add how I first got involved with Grace Center, I was attending Western Oregon University and went to Grace Center as an intern, and I had the opportunity to join the team. While I was there, I found that the staff were so great and caring. What was really rewarding for me to see firsthand how these participants were able to get the care they need while caregivers received respite. To see the impact Grace Center has on the community and what a valuable resource the Grace Center is, and to see how much these services are needed, community support really enables us to provide respite care, memory care, and our critical services, and that is why I joined the team. On behalf of Grace Center for Adult Day Services, I would like to thank everyone for attending the 4th Annual Aging Summit. The Aging Summit is primarily for education and community benefit. We are proud to bring together an amazing group of speakers and panelists to this event. It is a good opportunity to learn about aging, community resources, and Grace Center. So Grace Center is a specialized health and social adult day center located in Corvallis, Oregon. The only certified adult day center in the Len, Benton, and Polk counties. Grace Center is a unique and needed service for the Tri-County community it serves. Grace Center is a nonprofit organization, and we have the mission to provide day services that optimize the cognitive and physical abilities of seniors and adults with disabilities so they can remain independent and as possible and in their homes. Our vision statement is to be leaders in the new approach to long-term care that will change the way our culture views aging through innovative practices which keep families together and our communities intergenerational. Our 4 core values are equality by treating everyone we serve with compassion, dignity, and respect. Empowerment by supporting diversity, self-determination, and independence. Excellence by acting with integrity and striving for the highest quality care and service. And lastly, commitment by exceeding the expectations of those we serve and the standards we set for ourselves. The center specializes both in memory care and post-rehabilitation, serving adults with dementia, those recovering from strokes or brain injuries, and others. Grace Center services also provide vital respite care for family caregivers. Family caregivers depend on much needed respite to avoid stress and caregiver burnout. Many family members serve as full-time caregivers, while some work full-time and also provide part-time caregiving to their loved ones. Many of our participants and their families are utilizing Grace Center services to provide some much-needed respite. At Grace Center, our participants receive quality care while their family caregivers obtain the respite they need without having to worry. Some of our activities at Grace Center include live music, art, animal therapy, gardening, cooking, woodworking, and intergenerational activities with kids. Our exercise program includes seated weights, dowels, yoga, and leg exercises. We also provide standing balance, hand therapy, and an individualized exercise plan. At Grace Center, we have a participant wellness group that meets on Tuesdays and Wednesdays weekly. They participate so that their voices can be heard and they have an opportunity to gain support, resources, and feedback. The group will also cover topics ranging from self-care habits to finding support outside of the group. The participant wellness group is facilitated by Erin Mitchell, who is a professional counselor associate who has been working with Grace Center since 2018. Her work is client-centered. She uses a humanistic lens, and in addition to facilitating the wellness group, she also sees individual clients at the center. Erin also facilitates our caregiver support group that meets once a month in person from 3 to 4:30. The group support is open to all family caregivers, whether they are using Grace Center services or not. Erin brings warmth and guidance to overwhelmed caregivers. The group focuses on group discussion and sharing. There is also respite care available during the group. If you'd like more information on the caregiver support group, please call Grace Center's office or visit our website. If you would like to make a donation to Grace Center today, we have 4 anonymous donors who will each match up to $1,000 today. So if you donate $1, it automatically becomes $5. 100% of your donation goes straight to Grace Center. To donate, there will be a link in the chat box and you can click it and it will take you directly to the donation page. For donating with remit envelope, you have to write Aging Summit somewhere on the envelope and it will count towards the match today. The 2 top donors during the Aging Summit webinar will win a gift basket. The top donor will win a wonderful wellness basket donated by Grace Center. And the second top donor will receive an amazing gift basket from Lumina Hospice and Palliative Care. The winners will be contacted after the event, and gift baskets must be picked up at Grace Center. Lastly, I would like to thank our sponsors. Grace Center is able to offer this free educational event due to our community support and generous sponsors. We would like to thank this year's sponsors, our gold sponsor, Citizens Bank, our silver sponsor, Samaritan Health Services, and our 4 bronze sponsors, Good Earth Pest Company, Samaritan Evergreen Hospice, Timber Hill Place, and Town and Country Realty for their contributions. And Lumina Hospice for the top donor gift basket. We greatly appreciate our 4 top donors for the matching donations. A special thank you to all of our amazing speakers and panelists for their time and support today. And also, this webinar is being recorded, and a link will be sent out to everyone who has registered for the webinar.
Oh. Okay, thank you, Denise, for all that information. Now we're going to turn to our presentation. Our first speaker is Dr. Patrick Erbor, who will speak on the impact of loneliness on the physical and mental health of older adults. Dr. Erbor is the founder and the director of the Center of Elderly Suicide Prevention and Grief-Related Services, which is a program of the Institute of Aging in San Francisco. Patrick conducts workshops and presents lectures locally and nationally on aging-related subjects. At the end of Dr. Erbor's session, we'll take time for your questions. So if any time during his presentation you have any questions, please enter them in that Q&A tab on your screen. And then Dr. Erbor will try to get to as many as possible. Dr. Erbor, will you please welcome him?
Thank you very much. And I'm very honored to participate with you all this morning. And it's always a real important opportunity for me to talk about loneliness and social isolation and its impact on older people. And Ryan has graciously agreed to forward my slides. And if you could go to the next slide. And next slide. And, as you heard, I am the founder and director of the Center for Elderly Suicide Prevention and Grief-Related Services. One of our premier services is the Friendship Line. And I started this in 1973. So this is our 48th year of service. And I know, to look at me, you're all thinking he must have been a child prodigy because he looks so young. How could he start something back in 1973 and be doing this for 48 years? But it's been a passion of mine for a very long period of time. And one of the things that I was thinking about in preparation for today is that our training of not only our Friendship Line volunteers, but also our grief facilitators has to do with, focusing on letting people know, whether they call us on the Friendship Line and or they come to any of our grief groups, is that first of all, that they matter, and that they belong. I had a grief group last night, and we had 20 people there, and it was so beautiful. I asked them, why do you come to this monthly meeting? And they said they come because they want to be in a community with people who tell the truth, who are as authentic as they can be regarding grief and loss. Next slide, please. And so we also, have our grief services. They're all on the Zoom platform, and whether you're in Oregon or Massachusetts or Florida, wherever, you can always join our grief groups. We have Saturday morning drop-in groups as well as 8-week groups. And, people can attend from anywhere in the United States. That's one of the kind of blessings of this needing to move away from in-person because of the pandemic to Zoom, is that we have people from all over the country who are now Zoom joining our groups or calling Friendship Line. And the other thing that we train and focus on with our volunteers is empathy, to really empathize with people who are lonely or isolated. And that was one of the cornerstones of Friendship Line when I began it 48 years ago, was that it was built on the foundation that if we could help people decrease feelings of loneliness, decrease feelings of social isolation, that would have an impact on, on their mental and also physical health. Next slide. And as you know, Robin Williams died by suicide several years ago. And one of the things that he had said, and I think it's just so appropriate for this presentation this morning, is that he said, I used to think the worst thing in life was to end up all alone. It's not. The worst thing in life is to end up with people that make you feel all alone. And what he was really referring there to is, feeling isolated, that kind of feeling that you're isolated in a crowd. Next slide. And I'm not going to go into detail with, I include these slides because as an educator as well as a clinician, I always feel it's best to have, information that people might want to go back and look at or read. And I'm sure Sunita and people at the Grace Center can forward these slides to you if you need them. But just to say, that the population of older people 65 plus is just really going to continue to increase to about 95 million people by 2060. But also the population is becoming more racially and ethnically diverse as well. And I think that really does enrich the aging pool of people, but also tells us that we really want to increase our capacity to be culturally humble. Next slide. And I think it's also important for us to know kind of the overall scope of these issues is that in the United States, about 28% of community dwelling older people live alone. And that's based on data from March 2021. And 20% of them are men, and 34% of those who live alone are older women. But what's also very important is that the percent of people living alone increases with age, especially among women 75 plus. 44% of them live alone. Now, some older women live alone by choice and are very content. And those individuals we kind of refer to are people that enjoy solitude. For example, I'm 73, I'll be 74 this year, and I live alone. And I'm very happy living alone. And it's, I have family, etc., and friends. But I appreciate my solitude. I appreciate the relationship that I've built with myself over the years. Next slide. And again, this just validates what we were talking about. The number of older households age 80 and over is projected to reach 10.1 million by 2038. And I think it's a wake-up call for all of us that work in the field of aging and provide the kind of services such as the Grace Center provides, is that we need to be prepared for this uptick in aging individuals so that we are prepared to help them. I loved when Denise was talking about and Marilyn was talking about aging in place. And I think that this is really what we need to pay attention to. How do we support, uh, older people who really want to, maintain their sense of independence and autonomy, but they really need some support. Next slide. And what Surgeon General and author Vivek Murthy has proclaimed that loneliness and social isolation among the world's older population is a global epidemic. If you haven't read his book Together by Vivek Murthy, it's really a great book on loneliness and isolation, and I really appreciate his focus on how loneliness can really cause a lot of mental health and physical health problems among the elderly. And so I think it's really important that we have this topic today. Next slide. And what's important now, as we have gone through this pandemic, COVID-19, this pandemic has kind of forced us to focus increased attention on social isolation and loneliness for all ages, but particularly older adults who tend to be the most vulnerable at-risk segment of the population. Next slide. Separation from loved ones, the loss of freedom, uncertainty over disease status, and boredom can create traumatic effects. Suicide deaths have also been reported, and that's something that I'm really concerned about. And nationally, we're just not sure, what's going to happen, because back in 2007, 2008, with the Great Recession, what we saw was that suicide rates increased for, all age populations. And we just don't have data yet from 2020 or 20, certainly not 2021 yet. So I'm really concerned about that. And we know that loneliness and social isolation can be very difficult for people. I talk to older people and younger people every day on the phone or on Zoom. And what I hear are people saying, when is this going to be over? When are things going to get back to normal? Or people will say to me, are they going to get back to normal? Will we have just normal life again? And I think it's causing a lot of stress on our older family members and friends and neighbors. Next slide. So some of these psychological symptoms include emotional disturbance, depression, stress, irritability, insomnia, post-traumatic stress symptoms, anger, emotional exhaustion. I've been on Zoom meetings with, older members from the community, and what, much to my surprise, that people will make a comment and somebody else will disagree. And all of a sudden, it's not just, I just see things differently. It's, they're really angry at one another. And I think that, again, is the stress of all this uncertainty in which we live. Next slide. So who are the people who are greatest risk for isolation? Well, those with physical, sensory, and functional impairments. Certainly those who live alone, although what we want to make sure that we don't assume everybody who is older who lives alone is going to be lonely. As I said, some people choose to live alone because they're comfortable with solitude. We want to be thoughtful about people who are over the age of 80, those who are geographically isolated, people who live in rural parts, for example, of Oregon, those living on limited income, those with poor mental health. Next slide. And we want to really be able to talk to people about their social networks, because one of the things, and I think all of us who work in the field of aging recognize that it's very easy for people to slip from, being engaged into loneliness if they have a chronic illness, or if people close to them have moved to other geographic areas, those lacking instrumental support, those facing any kind of life transition. And we want to be sensitive to populations such as the LGBT community, military veterans, ethnic and racial minority groups, rural elderly, people living in poverty. Next slide. And thank you. You know, both isolation and loneliness are associated with increased mortality. And mortality was higher among socially isolated and more lonely participants. So loneliness, which, you know, I've been talking about for 48 years, but it hasn't been until about the last 5 or 6 years that people are really acknowledging that, yes, you know, loneliness can have, you know, have a physical impact. And really, people, it's almost like failure to thrive. You know, what we are as a human creature is that we are hardwired to affiliate, you know, and I'm sure many of you today, as you were getting prepared to come to this webinar, you know, we're talking with family. I saw Sunita earlier and it looked like she was there with her granddaughter. And, you know, we want to be connected. And so it can cause a lot of physical and mental health problems when those connections are not available for us. You know, so while both isolation and loneliness impair quality of life and well-being, efforts to reduce isolation are likely to be more relevant to mortality. Next slide. You know, and so the causes of isolation, such as absence of supportive significant other, not having a sense of purpose, not having a sense of meaning. That's why we train our staff and volunteers, you know, to remind people, regardless of their age, that they matter. They matter to the community. And, you know, and that's what I think of aging in place, you know, that the community really needs to kind of wrap our loving arms around older people and let them know that they are viable partners in the well-being of our communities. The other aspect here is the problem with hearing loss or vision loss. You know, sensory problems can have a terrible impact on loneliness. I was working with a 95-year-old man who was in very good physical health, but he could not hear, and hearing aids were no longer helpful. And he said to me one day, he said, I was giving a talk on loneliness and he was a participant. And he came up to me afterwards and he said, Patrick, I know you know a lot about loneliness, but he said, you really don't know what it feels like when you cannot hear anyone. And because of your low vision, you can't even read lips anymore. And he said, that's loneliness. Next slide. You know, and vision loss, as I said, can really create a problem psychologically in terms of feeling depressed and anxious. Next slide. And I just included these slides for those of you that want more information. So we'll go to the next slide, Ryan. You know, and again, social isolation is a significant public health problem, and its damages have been compared in scale with cigarette smoking. Dr. John Capiaccio has said that loneliness is correlated with people's health problems that occur when they have been smoking, I think, approximately 14 cigarettes a day for years and years and years. That loneliness can do as much damage. Older adults are especially prone to experience this as we get older. And isolated older people are at high risk for poor health outcomes, especially those with diabetes, cancer, coronary heart disease. Next slide, please. And we'll go to the next slide. So how do we recognize loneliness? Well, you know, the thing about loneliness and social isolated people is they withdraw, you know, and Dr. Cacioppo has also said that, and I know you probably have a sense of this too, or if I've heard other speakers talk about this, that being lonely, being socially isolated really affects, you know, parts of our brain. And that we if we've been lonely and isolated for quite a few years, what happens is that we don't trust anymore. We don't want to reach out to people. And so the lonely person often appears anxious or withdrawn or apathetic, can be very hostile sometimes. And so they're not the most attractive person at the senior center. And so a lot of people just don't go up to them and talk to them because it's going to be challenging. And so we need to kind of get past that and recognize that sometimes all you have to do is just sit beside a person. You don't have to say anything. You just want to sit beside them. You know, is the person eager for visitors and then distressed when they leave? You know, I'm sure many of you have had that, you know, opportunity to be talking to maybe an older neighbor, and then you say to them, well, you know, I've got to go because I've got things to do. And they might grab your shirt or your sweater and say, oh, can't you have another cup of coffee? Can't you stay a little longer? And it's really kind of heartbreaking. And that's why I think it's important, like Grace Center, that you have, you know, built into your community, you know, a program such as a Grace Center, and to know what other programs exist, such as Friendship Line or any other kind of program that can help support that older person and remind them that they matter. You know, next slide. And you know, I was just saying that the community is really important. It's one of the ways in which Dr. Parasanato and other people have said, you know, that senior communities such as Grace Center or senior centers in and around your community, you know, can have a strong correlation with senior communities and new supportive friendships, that we can, as we age, you know, reach out and connect with other people. But we need to have some forum or structure for that. Next slide. Go on to the next slide, please, Ryan. And this one is important because, you know, what we're recognizing, according to the research, is that people who are lonely, people who are isolated, you know, tend to have more of a, that are more susceptible to having cognitive problems or dementia. In a community-based sample of cognitively normal older adults, a higher in vivo cortical amyloid burden was associated with greater feelings of loneliness. And what this suggests, it's a neuropsychiatric symptom in preclinical Alzheimer's disease. So there are so many really important, you know, urgent, you know, problems associated with loneliness and social isolation. And again, I just am so happy and honored to be able to talk about this with you today. Next slide, please. You know, and this is just another study that was done recently in 2021. And it also provided evidence of a cognitive resilience associated between Alzheimer's disease and related disorder vulnerability, and a specific social intervention that can be of benefit, which is simply supportive listening. As I'm sure many of you today who work with the elderly or have elderly parents know, that listening can be very, very important. Next slide. And again, you know, isolation increases vulnerability to disease and can occur as a result of age or race, culture, frailty, poverty, appearance, sexual orientation, or stereotypical thinking. Next slide, Brian, please. And, you know, and because it has taken decades for evidence to emerge, because, you know, LGBT individuals or ethnic minority individuals have been often unseen. Data suggests that social isolation affects a disproportionate number of older individuals, who continued to have to deal with stigma, discrimination, ageism, racism, homophobia, and transphobia. Next slide, please. And what we know is that a lot of elderly LGBT individuals suffer from isolation, and we don't really have a whole lot of data on transgender elderly people, but it doesn't look good in terms of their capacity to stay engaged with other older people or younger people as they age. Next slide. And so what prevents these conversations about loneliness, isolation, depression, and grief? Why has it taken so many decades for us to get to a point where we can, really look at, loneliness among not only older people, but younger people? And it's because we lack a vocabulary. Somehow loneliness has had a connotation of being a loser, whether you're 90 or 22. And then ageism gets in the way as well, because there's still this belief that, well, of course, older people are going to be lonely. That's what it means to be old. And we've got to really debunk that. And then just resistance, that, as I said earlier, that people who are lonely or isolated often do not appear as people that are easily engaged. And so we resist that. Next slide. So we want to examine our own attitudes about aging and join or support groups that oppose ageism. And so would you, Ryan, go towards the back now before the reference list, because I know my time is growing short. So there's, keep going. Now back up one. So I just want to end on this. I've included information about being a burden. I've included information about belonging and mattering, and you can look at that as you will. But I just wanted to end with this by a quote by Leo Buscaglia. He says, "Too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around." And I hope that we will do this today when you leave this Zoom meeting and you are engaging your family or neighbors or friends, and I just be kind. And I know that even with a mask on, we can smile with our eyes. So thank you. And if anybody has any questions, I'd be happy to entertain them. Thank you.
Dr. Arbor, we do have one question on the Q&A. I live with my grandma and I know she will keep her feelings in to not worry me. I was just wondering if there are some signs to detect loneliness.
Well, I think that, as I was saying earlier, when somebody is withdrawn or someone, doesn't seem to engage in the way the person did in the past, or they might cling to the individual and want to hold on to somebody. If you are the grandson or granddaughter, you say to your grandmother, I'm going to go out, I'm going to go join friends, and that she might get very distressed about that. People that don't have strong social networks. So, I think it's important, even you asking that question kind of tells us that your grandmother might be feeling lonely. I want to make one comment too about emotions. What often people who are lonely that don't talk about how they feel. And emotions are not a luxury. They are a complex aid in the fight for our existence. we are physical people, we are emotional people, we are spiritual people, and we need to be able to communicate and draw someone out. So that's how I would respond to that.
Dr. Arbor, we have a couple of more questions that have come in. First question, if a person with lifelong social anxiety decides to retire from their lifelong social groups, what advice do you have for supporting them?
Well, first of all, I would want to explore with a person what is their motivation for withdrawing from social groups, you know, or as you said, retiring from social groups. I think that when we leave any kind of whether it's volunteer work or whether it's a group that you've been in with friends, or you know, it's retiring from a paying job, that is a major grief experience for people, and that's one of the, you know, concerns that I have about people who, you know, choose to, you know, leave a situation where they have been a member. I think that we need to explore the reasons for that, but also to look at the consequences of leaving. What is going to fill that space for an individual? So again, I would think about issues related to grief and loss, and how that particular space that used to be filled by these groups, what's going to take its place. And one of the things that we know, and there's a lot of older people right now who are sitting in front of their television sets watching, you know, Saturday morning TV. And we know that that's not necessarily the healthiest thing to do. I also know people, and I know you do too, who are sitting right now at a window, and they're looking outside, maybe to a sidewalk or a field, or and they're not conscious, you know, they're just staring, and that's another sign of loneliness. So we need to be able to, you know, we need to be able to connect and explore, you know, what are you doing when you're sitting there just staring out the window? See, again, the ageist attitude is, well, isn't Patrick, that's what old people do. And we've got to, you know, resist the temptation to accept that assumption. What we want to do is connect, you know, connections with others is what binds us to life. Is there another question?
Yes, Dr. Arbor.
Yes.
Do you have strategies to break the ice when we recognize somebody needs help, and encourage them to reach out to the warm line hotline, that national hotline that you were speaking of?
Well, absolutely. And, you know, what we want to do is to recognize a couple things. One is that people have been lonely and isolated for quite a long time, are not going to respond, you know, as we would like them to do when we say to someone that we perceive as lonely, and we say to them, you know, hey, I know this resource, you know, it might be the senior center that has some program that the person can come to. I think with the Grace Center, what I was hearing is that there are in-person groups now. And if we assume that the person is going to say, wow, that's what I need, thank you so much, that may not be their response. And I think it's always better to begin with somebody who's been lonely and isolated. We need to understand how long they have been lonely, how long they've been isolated, and what were the circumstances leading up to that. You know, were there deaths in the family? We know with COVID, you know, we have people in our grief group where this one woman who is in her 50s, her mother died of COVID, the father died of COVID, and her brother died of COVID. And so that was her, you know, family of origin, all gone, you know, in a matter of months. You know, she's very isolated, and she's grieving. So what we want to do is kind of make some assessments about, you know, what happened in that person's life that has them now being very lonely. And so building rapport, I think it's very important. Before I would say to somebody, here's a resource that you might want to take advantage of, I think we have to do, you know, a little bit more in-depth kind of conversation so that we can feel like this person would be willing to, say, call the friendship line. But I think it starts with engaging the individual, building some rapport, and recognizing that they may not jump at the chance to connect, because part of being lonely and isolated, as Dr. Cacioppo has said, is that they become quite suspicious of what the motivation is of someone to urge them to do something. So there's quite a bit that has to be done before a referral would be accepted by that individual. Something else? You know, I'm totally lost. I don't know what time it is at all.
We do have a few more questions, Dr. Arbor.
All right.
One refers back to the question you answered just a minute ago about if a person in a lifelong society, social anxiety, decides to retire from their lifelong social groups, what advice do you have for supporting them? You answered that question. Along that same line, do you have specific suggestions for an older person on where to start developing better social connections?
Well, you know, I think that that's really an important question. And again, my answer is going to be more longitudinal. I think that we have to start by encouraging the value and importance of connections, you know, connections to others. I think we have to really help young people, you know, develop those skills, you know, that are necessary to build healthy relationships. I'm sure many of you on this webinar have friends that you might have had since grammar school or since high school, because you learned how to communicate with people. So that's, I think, you know, the basic, the foundation, you know, of making sure that people understand how to have a conversation, and to understand the most important element in any conversation is honesty. You know, to be honest, to be able to, you know, self-disclose something about yourself when you are meeting another person. That's why I think, you know, senior centers, you know, or the Grace Center, you know, or for example, Friendship Line, that what we want to do is to really connect with people and, you know, and create a connection, you know, that, and we do that through conversation. We do that through expressions of empathy. We do that through expressions of compassion and interest, you know, and that's what I think that a lot of programs that involve seniors, I think that that's a lot of what people are doing now, is really teaching older people how to communicate. There's a program that's offered by the National Council on Aging, and it's an aging mastery program. And one of the segments is on how do you maintain and build healthy relationships so that as you age, you don't lose relationships, you build connections. So, you know, so those are some of the things that I would encourage. But it's really, again, it comes down, I think the common denominator in my statements are education. We need to educate, you know, younger people about the truth, and that's why I showed those slides earlier about, people getting older, is that, you shall one day be old as well. And so we've got to put some energy in combating ageist attitudes and ageism, just as we're trying to do with racism and sexism and homophobia. Ageism gets in the way of older people really being able to feel vital and that they matter in older age. So I know that's a long-winded answer to your question, but I hope that gets to the point of it.
Well, we have just a couple more questions here. So do you think our reliance, pardon me, do you think our reliance on connecting via social media or even just via text messaging can create more reluctance on our part to actually engage with someone in person? It seems like our reliance on devices to connect makes us hesitant to actually talk to someone. If we were shy to begin with, our use of devices can exacerbate this. How do we overcome that?
Well, again, that's, I think, a really important question. And there's a number of research studies have been done. One of the things that we see by being, on Zoom or that type of platform is that there is a Zoom fatigue. I'm sure that many of you have experienced that. And, but also I think with Zoom, what I'm finding out with my older adults is that, for example, last night, there were 20 older people on this, with all their Brady Bunch squares. And afterwards, a number of them emailed me and said what they are starting to realize is that there is the opportunity for intimacy on this Zoom platform, because at a meeting with 20 people, you really don't see everyone, and this one gentleman said, what I like about it is I see their faces without masks, and I can see their eyes, and I can see, the tears as they were talking about losses. And he said, I'm so surprised that Zoom really has an opportunity to kind of build a type of intimacy that I didn't think could happen. So I think, again, that our use of the Zoom platform can have benefits, and can even without the physical presence and the energy of the human spirit, we can still pick it up. So I think that can be helpful. I think things like texting, a lot of my older clients, especially those that have arthritis, I have arthritis in my fingers, and they'll say to me, it's very hard for me to text, I can't do it, or my vision is poor, I can't see it. Like, for example, I can't read what comes up in that Q&A or chat because it's just too small and it's hard for me to see it. The other thing, though, that I think is crucial, and I've talked to the AARP Regional Committee here in California about it, is a lot of my clients are, live alone and are on limited incomes, and they don't have access to laptops or iPads. And the ones that do have laptops don't know how to use them, don't know what the functions are, and get very stressed. One of my clients last night, it took her a half hour to get on. She just couldn't figure out how to tap into the link. And so I think what we have to really consider is training for older people to utilize. However, there's an ageist attitude there too that we have to overcome, which is older people cannot learn new things, which is not true. What we have to have are patient people who can help us, and I think we can learn how to use these devices. But we also have to find a way to get devices into people's hands. And that's, that's something we have to consider. because it doesn't seem at this point that Zoom is going to go away. But I do think FaceTime, Zoom is much more, creates more of a connection than texting or emails. I think older people can respond better to the visual, if their vision and hearing are relatively okay.
Excellent. Just so you know, Dr. Arbor, we have about 8 more minutes to go here and a few more questions. We have a couple of questions that follow a common thread on loneliness. First would be, how do you help an older adult who wants to stay alone and does not recognize they are lonely?
And this is, and I really like that question because it, again, triggers my thinking about the need to probe a little bit, because of the negative connotation around saying, I am lonely, or, I feel sad and lonely, that sort of thing. And I think there's a gender issue as well, because many of my older male clients, even pre-COVID, visually, if I was doing a home visit, I could just see by the expression on their face that something was wrong. They looked sad. They looked like they were withdrawing. And then when I would have a conversation with them, and I would, again, build some rapport before I would say something about being lonely, but I would ask them about losses that they might have had or that sort of thing. But I could see their resistance, to actually using the terms lonely or sad, or feeling isolated. Whereas I find that my older women clients were more able to, access their emotions. And I'm not saying all older women are easily able to do that, but I just think that they are a little bit better conditioned to accept emotions. But I think it's very hard, again, because of the connotation. So one of the things I say in my trainings about loneliness is, first of all, how do you, all of us on this Zoom, how do we define loneliness for ourselves? And has there been a time in your life when you felt lonely? And how did you know you were lonely? And how did you change that? And I think if we as neighbors or family members or workers in the field of aging would sit and reflect on our own experience with loneliness, I think that that would really help us relate better and connect better with other people who are resisting telling us about their loneliness. I think if it starts with our own reflection on what it was like for me, I think that increases our empathy and our vocabulary when we talk to older people who we think might be feeling lonely.
So along that same line, how can children help older adults who complain about being alone and lonely, but refuse to accept that?
Yeah, see, that's another, I think, a big question. If we're thinking about adult children and older parents, and I hear this often, from older parents who had, I remember this one woman who was in her 60s, and she said that she thought, excuse me, that, with her 2 sons, that as she got older and they got older, she thought they would become closer to one another. Because she said when she grew up, the whole thing about her childhood was at 18, you leave, you get a job, or you go to the army, or you go, to school, but you move on. And she said, you know, and she had been close to her parents, but she said it wasn't the most, um, it wasn't the deepest kind of a relationship. But she thought, oh, it would be different for her and her two sons. And then what she found, and I hear this many, many times from people, that the relationship isn't as close as she had hoped it would be. Um, and 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 I think what it has to do with is recognizing that your parent has gotten older, and especially when they're in the 70 to 80 age category or the 80 to 90 age category. Research has indicated that a lot of adult children, when they notice vulnerabilities in their older parent, you know, such as mobility problems, or, you know, we forget a word here or there, or we make mistakes with our schedules, that the adult children often feel an experience of shame or embarrassment that the parent is getting old. And again, it goes back to ageism, that old has a very negative connotation. And so again, I think parents, you know, who are younger and have, let's say, teenagers or younger, really need to start acknowledging that, you know, the life continuum means that we're all aging. You know, 80-year-old people didn't pop out of the womb at 80. They were 79, they were 69, you know, they were teenagers. And again, in an ageist society, I think that that problems do exist between the generations. Um, and that's why I really, you know, lobby for families, you know, church groups, you know, having conversations with intergenerational groups about the process of aging, and have older people say what it means to them. Not everybody has financial resources. Not everybody has good health. You know, not everybody has strong genetic background. Uh, so we need to kind of deal with ableism as well as ageism, and not have a group that of the healthy people who grow older have a better life than other people who don't have such good genetic qualities.
Excellent. Well, we're running out of time, but I'll ask one more question, and then basically what we will do is, for any questions that have not been able to be answered, we'll take what's remaining, and please send any additional questions you may have to the Grace Center, and we will be sure to forward those to the speakers for an answer. And you're welcome to mail your email questions to office@gracecenter-corvallis.org, and we'll get that posted as well. Anyway, one final question. You mentioned educating the younger generation on communicating and building connections. The attendee is wondering, how can they guide their grandparents so they can open up more and build that connection?
Well, and again, I think what any of this has to do with in terms of a strategy has to do with, you know, creating conversations among, you know, different generations rather than confrontations. And I think that we need to invite the grandparents, you know, to, you know, sit down with grandchildren, you know, and really, you know, talk to one another, rather than just looking at old people as, you know, again, from an ageist lens, that, you know, there isn't much there for them because a lot of older people are retired or whatnot. And I think we have to, again, create a vocabulary. And how do we do that? We do it through conversation, but it's also, I think, through reading, you know, that we find a way for older people to kind of get a sense of where they are, you know, on that age continuum. I love that you're going to have a speaker on end of life care. I think that is one of the things that I think, young adults have trouble with, because the, psychological context for younger people is often, they don't think that when I go to bed tonight, I might not wake up tomorrow. But for many of us who are older, I mean, I think about that, will I wake up tomorrow? I hope I will, but it's not as guaranteed as it was when I was 30. But again, I think we need to have more, films, theatrical films about older people. I think we need to have more books written by and about what it means to age. There's a wonderful book by Louise Aronson called Elderhood that I think is really, really good. Thomas More has a spiritual book called Ageless Soul, S-O-U-L, which is really good. And I think there are other, books and other, ways to kind of create a conversation. So those are some of the things I would suggest.
Okay, thank you very much, Dr. Erbor. We really appreciate your presentation, the time you've taken today to be with us, and also for taking the time to answer all these questions.
You're welcome.
We will now take a 10-minute break. And then when we come back, our next speaker will be Barbara Hansen. So we've got about 10 minutes till a little after, quarter after 10. Thank you. Good morning again. We're ready to start our next session. Our next speaker is going to be Barbara Hansen, who will be speaking on advanced care planning for end of life and what may be covered and who's going to pay. Barbara currently serves as the CEO of Oregon Hospice and Palliative Care Association, and she's the executive director of the Washington State Hospice and Palliative Care Association organization. Now, like the prior presentation, if you have any questions during Barb's presentation, please enter them in the Q&A tab. During Barb's talk, our moderators will be forwarding your questions to Barbara, and she'll be answering them periodically through her session. So please welcome Barbara Hansen.
Great, thank you so much. I just want to make sure folks can hear me okay.
I can.
You sound
Okay,
good.
perfect, thank you. And I'm going to share my screen and let me do that from the beginning. There we go. Okay, and can everybody see my slides okay? Yes. Okay, great. Great. So thank you, Marilyn, for that nice introduction. And thanks everybody for giving up part of your beautiful Saturday morning to attend this Aging Summit. I have participated in the past as an attendee and also as a presenter. And so I was flattered to be asked to come back and present again this year, but I always get such wonderful information. And that was certainly true from Dr. Arbor's presentation. So as Marilyn said, I'm happy to be interrupted if you have a certain question, relating to a certain slide. Please feel free to put that in the Q&A box. And I know there are folks who are monitoring the chat as well. So as Marilyn said, I do work with both the Oregon and Washington State Hospice organizations. I work with about 100 hospice programs through my work with both of those states. And I have worked in hospice since about 1986. So I do go back quite a few years. I also am privileged to serve as a board member for the Grace Center for Adult Day Services. So I am in the habit of always including objectives for any presentation I give. So if you find that I'm not covering something in the detail that you would like, please hold me accountable, and I'm happy to come back and discuss anything in more detail. I also am used to offering a disclosure, and I have no disclosures, nobody is paying me for this presentation this morning. I don't work for big pharma, any pharmaceutical companies. I don't work for any managed care organizations or anybody like that. So I like to start off with a brief reflection. Before we go any further, let's think about the past, gosh, it's getting to be 19 months now. And if we think about all we have lost, and I tried to find earlier this week a statistic about how many deaths we have in the United States have suffered from the COVID pandemic. And that no figures agreed, but it was all at least 672,000. And in some estimates, I think it's above 675,000. So it's a lot of our fellow Americans. I think almost everybody knows somebody, well, definitely we know somebody who has had COVID. And many of us know somebody who has died of COVID. We've just suffered a tremendous loss. And we have lost more than were lost in the 1918 Spanish flu pandemic. So that's another sobering statistic. And if we think about also what have we learned, and as Dr. Arbor mentioned, we have learned to communicate more virtually than we ever had before. It's now the norm for us all to, if we have to go to a meeting, for a virtual option to be not only offered, but required or at least encouraged. And I don't think we're ever going to go back from that. I think once we've gotten used to the benefits and we've mastered the technology, we're going to continue to have virtual meeting options, which will hopefully increase our ability to participate in society and in meetings. So what have we learned about the healthcare system in the past 19 months? You know, we can, I tried to include the gymnasts to have us discuss if we think the healthcare system has become more flexible. And certainly there was a huge pivot made to be able to do visits through telehealth. That's one example of a flexibility that wasn't in play quite so much before, and even telephone call, not audio visual, but audio only. So our healthcare system has become more flexible in that regards. But if we look at, you know, ask ourselves if everybody's needs were met equally, and was there equity in the provision of healthcare, or some of the provider relief funds that have been available in the last 19 months, you know, we might say, oh, not so much. And overall, I think the verdict is still out about whether we think our healthcare system has worked, quote unquote. Certainly we have gotten more flexible, but whether everybody's healthcare needs have been met, probably we'd have to say no, because there's so much healthcare has been deferred. Even routine examinations or screening for cancer or hypertension or other diseases have all been put off in the last 19 months. So I almost called this session, "What's Wrong with End of Life Care in this Country?" But I try to be an optimistic person and have a, you know, a more optimistic viewpoint. So I didn't want to call it that. But having worked in end of life care and palliative care since 1986, I do have a few opinions about some things that could be improved. So if we look at how we compare the United States, one of the wealthiest countries in the world, I don't know if we are the wealthiest country. Maybe some of you have more expertise on that than I, but certainly in the, you know, in the industrialized world, we're one of the top countries, but our healthcare system is not as good. If you look at comparable countries, we have more disease burden. We rank last in healthcare access and quality. Our hospital admission rates are higher. And then when we're in the hospital or even at an outpatient appointment, we are more likely in the United States to experience a medical error or some sort of adverse event or outcome. And, you know, none of these statistics are anything that we should take any pride in. And again, if we look at since the pandemic came out in March of last year, we still lead the whole world in the number of cases and deaths. We have a higher per capita death rate than in many similarly wealthy countries. Our mortality and disease burden rates, they were already worse in the US than other peer countries. And yet our healthcare spending is much higher than most other countries, but we're just not getting the results back from our investment in healthcare spending. And again, these were statistics, that don't reflect 2021. It's really more looking back from last year. So when I think of our healthcare system, I think of systems not communicating with each other. So I know a phrase that's often used is we exist in these silos. And I grew up in the country, so I know what a silo looks like. I think maybe sometimes more urban people don't understand even what a silo is unless they've seen something on television or in the movies. But the main silos are hospital or inpatient care of any kind, and then outpatient care of any kind. LTC stands for long-term care facility care. And that could include lots of different kinds of long-term care facilities. Even assisted living facilities might be lumped under a long-term care facility umbrella or silo. And some healthcare systems or long-term care systems have lots of different types of long-term care facilities under their umbrella or their silo. An adult foster home could be another example of a long-term care facility. So it's not just nursing homes that I'm including in that silo. And then home care has actually several different types of services under that umbrella or silo. So there is a Medicare covered home health care and Medicare covered hospice care. And there's also what's called private duty home care. It's also confusingly referred to as in-home care, which is crazy making for all of us because all of home care is presumably occurs in someone's home, wherever that residence might be. And the home, by the way, could also be a type of facility that fits under the long-term care facility silo or umbrella. So anyway, it's very confusing, but in home care, there are two main types of care that are paid for by Medicare or some private insurance or Medicare Advantage programs, and that's home health care and hospice care. And then there's lots of different kinds of private duty home care. So, and what we're supposed to talk about advanced care planning. And I thought, wow, I probably should define that. I think most of us have some idea of what advanced care planning is, but it's one of those funny phrases that could be construed to be a noun, an adjective, maybe even a verb if you're doing advanced care planning. So there is a defined benefit under the Medicare program. And I should just say, I'm going to probably use the word Medicare more, Medicare covered, but most insurance companies and definitely Medicare Advantage managed care organizations do whatever Medicare does. So under Medicare, and CMS is the Center for Medicare and Medicaid Services. It really should be CMMS, but that doesn't roll off the tongue quite as well as CMS. So Center for Medicare Services says advanced care planning is a face-to-face service. And I also put in at the bottom of the slide a picture of a telehealth version of that because it is covered under telehealth also by Medicare, between a Medicare physician, or it could be a nurse practitioner or a physician assistant, and a patient, and me, say, to discuss my healthcare wishes if I'm unable to make decisions about their care. And why this is a big deal about that Medicare defines advanced care planning is because they pay for it. So that it became a covered service. Gosh, I should know this, maybe 2018, 2019, anyway, just within the last few years. And the primary goal of ACP, or advanced care planning, is to make sure that the care you receive is what you want to receive, and that you don't receive lots of care that you really never wanted to receive. So that's the whole goal. And from CMS's viewpoint, let's be honest, it also saves the healthcare system money. If you don't want to go on a ventilator, and that is clearly discussed with your physician, then chances are your physician isn't going to order you to be on a ventilator in an intensive care unit. And that's going to save the Medicare program dollars. But it's really about being consistent with your wishes. So the advanced care planning visit can be a component of what's called an advanced wellness visit. And that's a visit that can take place every 12 months just to update between you and your primary care provider, which could be a physician, nurse practitioner, or physician assistant, and Medicare pays for it 100%. If your provider accepts Medicare assignment, there's no copay with this kind of advanced wellness visit. So again, advanced care planning can be one component of that annual wellness visit. And the reason I put the other pictures on the slides is that advanced care planning is not done during that annual wellness visit as much as it could be. Sometimes advanced care planning is taking place in the emergency room as the physician is asking you what you want, or what if you have a family member there and you're not able to speak for yourself, they're asking that family member what you would want. And it also takes place in an intensive care unit. So it's way better to do it in advance of needing an emergency room visit or an ICU stay. So that's hence the name, advanced care planning. So other ways of thinking about in the total big picture view of what advanced care planning can mean, it really means, a series of activities. You can't just get it all done in one 20-minute visit with your physician or nurse practitioner or PA every 12 months. You really have to think in advance about what you would like to have happen. And then you have to talk about that. This really isn't good if it's a secret from everybody. So you want to talk about it with your family, if you have family, with your friends. So anybody that you want to know about what your wishes are, especially if you've named a healthcare representative. And I know Marilyn is an attorney and works with lots of people on advanced care planning from a legal standpoint. So maybe if I get any specific questions, I may defer those your way, Marilyn. Anyway, and it also includes assessing your resources. Do you have long-term care insurance that might kick in and help cover care you might need in the future? Do you have money socked away for a rainy day that might pay for any out-of-pocket expenses? Do you have funds put aside to pay for caregiving should you need to hire private duty caregiving? And do you have possible caregivers in your family or friends or neighbors or somebody you know about from church? Or is there a company that you know about that offers caregiving that you've heard good reports about, and you think, well, I would want them to help me if I need that care? So again, you have to look at all of your resources, and the majority of caregiving in our country is done by unpaid family caregivers, often a spouse. But again, you want to assess your resources. And then the most important thing is to document what you would like to have done in case you aren't able to express your wishes. So again, the Center for Medicare and Medicaid says, communication avoids confusion. And it's one of the greatest gifts you can give your family and your friends if you do communicate what your wishes are ahead of time, because when the time comes, if you're not able to speak for yourself, and I say this from personal experience, to have to try to figure out what you think your loved one would want when you've never had a conversation about it is a really challenging position. I wouldn't wish that on anybody. So I'm going to share 3 recent real life examples that I've had in the past month or so. In my role with the Washington and Oregon Hospice Associations, both of those organizations are public benefit organizations, nonprofit, and they also serve any resident in Oregon or Washington who has questions about hospice or palliative care, if they need information, if they need to know which hospice programs serve their loved one in a certain county, we are happy to provide that information. So I just get calls sometimes, and sometimes it's from people in Oregon or Washington, and sometimes it's from people across the country who have usually an elderly relative who lives here, and they want to know what the options are. So I had somebody call me a few weeks ago from the eastern part of the state, and they said, I've heard about palliative care. I'd like to sign up to receive it. I don't think I'm ready for hospice yet. I think my physician told me I might have another couple of years to live. I believe this was someone in their 80s, but it really could be anybody at any age. And she said, where can I get palliative care in my area? You know, the thing about palliative care is, and we're going to talk about it more in a minute, it's not one defined benefit. It's sort of this nebulous set of services that may or may not be available in the area where you live, depending on what the healthcare provider resources are in that area. So this was a person in the eastern part of the state. And if you live in Western Oregon or Western Washington, especially along the I-5 corridor, chances are really good that you could find a palliative care provider. You could find an outpatient clinic. And let me back up a little bit, because palliative care as an inpatient consultation service is available at almost every hospital in Oregon and Washington. It would be rare for it to not be available. Sometimes it may be that the palliative care consultant physician is off for the evening, but will be back tomorrow morning. So not every hospital has 24-hour a day, 7-day a week palliative care consult services, but they generally have something in place. But this person wasn't in the hospital. She wasn't anticipating going to the hospital, but she wanted to go talk about what services she might receive under palliative care. And she lived in Eastern Oregon, where I don't know of any outpatient palliative care providers. So that's one example. And let me move on to the second example. So this is a gap in our healthcare system. Should we have completed an advance directive? Two friends of mine experienced this unfortunate situation earlier this summer. One was going in to have elective surgery, and they had received from the hospital this packet of materials, which included information about how to complete an advance directive. And the wife said to the husband, should we do that? Should we go ahead and fill this out? And he said, no, you know what I would want. And so they didn't complete an advance directive. They didn't have an earlier version of an advance directive completed. And he experienced some complications after surgery, this elective surgery, and had some downturns in his care, it wasn't anything on the healthcare system. He just had some medical challenges. And as a result, he ended up dying from the downturns in his health that were experienced after the surgery. And several times during the course of his probably about 8 weeks in the hospital, and he did not have COVID, it was just other health downturns that could have occurred in any year, but they did occur during a pandemic. But his wife was approached and asked about, did he have an advance directive and what were his medical wishes? And she said it was not a burden to her or their 2 adult children to be asked these questions. But I said to her, and she consulted me just to, get some of the medical jargon explained, etc. And I said, well, I know you're saying it's not a burden, but gosh, wouldn't it be nice to know what he would want? And if he would want to be on a ventilator, for example, and so they didn't perceive it. They didn't complain about it as a burden, but I know from my own personal experience with a family member, maybe burden is the right word, but it's a lot of pressure. You want to do the right thing. You want to do what your loved one wants. And so if you can complete an advance directive so that everybody knows what you would want in certain situations, that's a gift to your family. And then another question that just came up to me last week, somebody was, it was a daughter wanting to have her elderly father come home from the hospital. He was currently in the hospital, and the doctors had told them it was time for him to go on hospice. And she wanted to know what her caregiving options were if she wanted to take her loved one home. She didn't want to have him have to go to a nursing home or adult foster home if they could possibly take him home. And it's just a challenge unless you have the funding to pay for services in your home. It's a challenge to find a program and to afford their services. And I think they will do a combination of family members stepping in, augmented by some in-home care that they're able to afford. They did not have long-term care insurance. So anyway, those are just 3 recent real-life examples from the last couple of months that I know I have experienced. So let's talk a little bit more to try to explain what's meant by some of these different terms. So what's in a name? All of these services are really offering the same type of care. These are services offered on an inpatient or outpatient basis. And these latter 3, serious illness care, supportive services, and complex care, are all names that were chosen by palliative care programs because they didn't think anybody really understood what palliative care was, and they didn't want to frighten people off. I know one program chose the name supportive services because they were receiving a lot of feedback from patients and families. They would come and visit and say, oh, I think you're with hospice and we're not ready for hospice. And many of these programs are completely separate programs from hospice, but they changed their name to just try to diminish the fear that came into people's eyes. And a program called Complex Care Services, their physician director told me, he said, yeah, people didn't like us when we were called palliative care, but we found out if we called ourselves complex care, people didn't mind the idea that maybe they needed complex care because we're all complicated human beings and we all want to have our wishes followed. And it's okay to be a bit of a diva at the end of life if you're indicating what your wishes are. So anyway, it's just kind of funny to me that all of these names refer to the same kind of service. So there are similar definitions for serious illness or serious illness care. And I would say over about the past 4 or 5 years, the phrase palliative care is sort of morphing into serious illness care because it's becoming more about managing long-term chronic illness and not necessarily a quote unquote pre-hospice service. So it's really a health condition that may carry a high risk of mortality, could affect someone for several years, can be a chronic illness. And the whole point of serious illness care, like palliative care, is to focus on managing symptoms and optimizing someone's quality of life. So you really want to be able to have people on a sort of a routine and a medication regime that helps them manage their symptoms. And maybe they're getting different types of therapy, whether it's physical therapy or occupational or speech therapy or any respiratory therapy, doing routine treatments at home to optimize their body system so that they can have the highest quality of life as possible. Let's see. So the Center to Advance Palliative Care is sort of the national clearinghouse of all sorts of wonderful information and resources about palliative care. And again, it's very similar to serious illness care. It's really helping people focus on how they can live with a serious illness and manage the symptoms and improve quality of life. And by the way, I have some links at the end of this slide presentation, and I also have on a reference slide, but I've also put some links on certain slides. And as I understand it, the Grace Center will be sharing our PDF version of our slides with anybody who wants it. So now we're going to shift gears a little bit from not what is a certain kind of care, serious illness care, but more into the who's paying for it, how is it covered discussion. And there are several different parts of Medicare. Most of us, I think, until we do a little bit of a deep dive, think of Medicare as just one sort of payment system. And I have to also share that I turn 65 next month. So I am Medicare eligible as of October 1st, which is next Friday. And I have never gotten more mail in my life than I have over the past few months, as all of these Medicare Advantage programs have sent me flyers and packets and say, a little birdie told us that you're going to be Medicare eligible on October 1st, and won't you come and sign up on our program? So it is massively confusing to try to figure out all the different components of Medicare, but this slide tries to break it down a little bit. So Medicare Part A is what I think most of us think of when we think of Medicare, and that covers our inpatient care in a hospital, the first 100 days or so of care at a skilled nursing facility, if we have care that we need, that a nurse has to provide, for example, or therapy that we're receiving. Hospice care and home health care are also covered under Medicare Part A. And then Medicare Part B is really more about the outpatient services or ambulance care or medical supplies and medical equipment like wheelchairs and walkers, hospital beds, bedside commodes, those sorts of things are covered under a Medicare Part B benefit. And that's an optional benefit that Medicare beneficiaries have to pay for every month. And there is some coverage under Medicare Part B for outpatient prescription drugs, but the majority of drugs are covered over to the right of the slide, which is under Medicare Part D. And then let me just jump quickly to Medicare Part C also. That's where most of the managed care organizations who provide Medicare Advantage plans, they're under Medicare Part C. And then, as I mentioned, Medicare Part D is really about drugs. And I have a Where's Waldo little clip art there. And he's asking, where's palliative care, right? You don't see palliative care listed under any of these parts of Medicare. And the answer is really palliative care could be listed under all four of those components. And we'll talk about that more in a minute. So Medicare doesn't cover everything. So I always think it's important to mention that as well. It doesn't cover custodial care, and we'll talk about that more in a minute. And it doesn't cover dental care or dentures, your vision exams. If you're having eye problems related to, say, cataracts or glaucoma, a medical condition, then Medicare would cover eye exams, but not related to getting new glasses or contact lenses. Medicare doesn't cover cosmetic surgery, doesn't cover acupuncture, hearing aids, routine foot care, or again, custodial care. And so let's dive in a little bit to talk about what is custodial care that is not covered by Medicare. And it's really sort of related to your activities of daily living, your personal care activities, getting in and out of bed, getting assistance with bathing, dressing, eating. And Medicare doesn't cover this. It calls it custodial care, thinking that you should either be able to do it yourself or have family members or friends who can assist you, or you have the resources to hire private duty in-home care, or you live somewhere where nurses' aides and other assistants are available to help you with these activities of daily living. And that could be in a nursing home or an assisted living facility that has those services available. But Medicare doesn't cover those routine activities of daily living that allow you to get out of bed if you're able to, or to be bathed in bed if you're not able to get out. Medicare doesn't cover those things unless you also need some sort of skilled service. Then Medicare may cover custodial care for short term. So Medicare has this infographic that I've copied onto a slide where they try to differentiate the difference between custodial care and skilled care. And then I added payment is required for custodial care, and Medicare will pay for skilled care providing certain conditions are met. I won't spend a lot more time on that slide, but invite you to take a look later. So I'm going to relabel our silos now, because these are the programs under Medicare that have what's called defined benefit programs with specific eligibility criteria. And you can see Waldo is still down in the corner saying, where's palliative care? And palliative care, because it's not a standalone defined Medicare benefit, could exist under any of these silos, but doesn't have its own silo. Don't know if that makes sense. So where can it be provided? It could be provided in an acute inpatient setting, which is Medicare's fancy lingo for basically a hospital. And again, almost every hospital has some type of palliative care consult service. It could be provided at your home from a home health provider, at your home from a hospice provider. It could be provided in any kind of long-term care facility, including a skilled nursing facility, if that facility either provides it on its own or contracts with somebody or allows somebody to come in to provide palliative care consults. It can be provided during physician office visits as an outpatient. And it can be provided during outpatient therapy appointments. Again, speech, physical therapy, occupational therapy, respiratory therapy, any sort of therapy appointment like that. And it could be also provided while receiving end-stage renal disease care. And again, that's a specific Medicare benefit program, end-stage renal disease. It's one of those silos. And here's another CMS graph or infographic that shows the difference between palliative care and hospice care. And you could substitute for palliative care, serious illness care. It's really could be years upstream from somebody qualifying for hospice. So to qualify for hospice care, someone has to have a 6-month or less prognosis. And a physician has to make that determination. But palliative care could be someone dealing with a chronic disease that may get worse in the next few years, like COPD or heart disease. And it could get worse and the person could then qualify for hospice care, but there could be a couple of years, 5 years, where they could qualify for palliative care to focus on managing symptoms and improving quality of life. Under hospice care, when somebody elects hospice care, they have a 6-month prognosis and they're giving up their regular Medicare coverage to have hospice treat anything related to their terminal disease. And they tend not to use life-prolonging medications, and someone cannot be seeking curative care for the same terminal diagnosis as to why they're on hospice. So you couldn't continue chemotherapy, say, when somebody is on hospice care, unless it's very short term and it's going to just solve a symptom issue. But under palliative care, you could continue to receive chemotherapy or radiation therapy or any sort of life-prolonging medication or treatment. So again, this is another slide that just shows a difference between serious illness or palliative care and hospice care. And I think I really covered it more. Both of them focus on comfort care, but hospice is typically closer to the end of life. In Oregon, the median length of stay on hospice is about 3 weeks or a little less. So that's where half of hospice patients are on a little longer than that, and half are on less than about 3 weeks. And this statistic has stayed the same for the 30 plus years I've been working in hospice. About a quarter of all hospice patients die in the first week of care. So we as a society, and that's across the country, that's not just in Oregon, we as a society really put off going on hospice care so much that a quarter of our hospice patients die in less than a week. So let's focus again on where it would be ideal to receive palliative care. And I think most of us who say it would be wherever we live. If we could get it in our home and we could call somebody if we had a question in the middle of the night about a medication or whatever it might be. So this is just about, you know, sort of the idea. And everything on the right side is a possible payment source from those different locations where you could receive palliative care. And I have that little clipboard showing that says that whoever is providing your care must document frequently that you are still eligible to receive coverage for that care. So it's very complicated. And again, it's because palliative care is not a standalone benefit. In order to receive these different types of care and to have a little palliative care worked in, there are eligibility and documentation requirements. All right, and then a question comes up about who coordinates your care. And that can vary from program to program. So it's really a challenge. It could be the patient or a family member who's sort of coordinating all the disparate care being provided and managing it all together. But in our society, it could be a bit fragmented. So this is my pie in the sky graphic. If we could design this ideal form of serious illness or palliative care, what might it look like? It would be provided in my home. It would be easy to qualify to receive. Somebody would be coordinating the care, and I would have the right folks to meet my needs, whether that's an aide to help me with my bathing or a therapist to help get me walking again. And it would last as long as I would need it, and I would get to participate in creating this plan. And of course, it would be licensed, regulated, bonded, insured, you know, somebody looking out to make sure that this is a reputable organization providing it. And then the billing would be easy. Ideally, I don't even see the billing. My palliative care provider bills Medicare or my HMO, and it's all, you know, paid for. It's all covered. So I just want to mention that our CMS is flirting with some ideas about providing serious illness care. And under their Innovation Center, they have 3 different types of trial programs beginning that would focus more on care outside the hospital. And I'm only going to cover the 3rd one, and I'll try to do it quickly. The Medicare Care Choices model was this innovative program that began several years ago, and it was for hospices to provide care to pre-hospice patients. So it was extended through this year. And it was basically for Medicare and Medicaid beneficiaries who were hospice eligible, but didn't really want to go on hospice yet. And they had to be at home and not living in a facility. And they had to have a certain diagnosis, and I have them listed there. So it was somewhat limited. This was a pilot project for patients with these kinds of diagnoses who were in a home, didn't want to go on hospice yet. And the hospice would agree to see that patient and coordinate their care pre-hospice. And the hospice received a little stipend of money every month, from $200 to $400 a month, to sort of case manage these patients. And again, these were not hospice patients, and there was no obligation for the person to go on hospice. And these were the different services that were being provided these patients. And I believe there were about 140 hospice programs across the country who were participating in this trial. So they were providing a lot of the services they might provide to somebody on hospice, maybe not quite as much in-person visits, maybe just a once a month visit, or some more telephone calls every week, and just sort of managing the person's care. There were some problems, and I won't go into those. Many hospice programs found that they were spending more than they were receiving to manage these people's care and to do visits, etc. There were eligibility challenges, but here's the slide I wanted to get to. Medicare really likes the Medicare Care Choices program because there was a 25% decrease in total Medicare expenditures. People who were on this program did go on hospice about a week earlier than patients who were not on this program, if they were compared to patients with similar diagnoses, etc. And there was great positive feedback from the recipients of the program. And I think I show that better on this slide. So again, that 25% decrease in Medicare expenses was hugely, favorable to Medicare. And 96% of caregivers indicated they would probably recommend this model to friends and family. So the key takeaways after 3 years, again, decrease in Medicare spending, lots of savings, and caregivers reporting positive experiences. And why I've told you about the Medicare Care Choices program is because a bill was introduced in Congress on July 29th of this year, and it was about a demonstration project for community-based palliative care. And it's because Medicare was so happy with the Medicare Care Choices model. And also in Oregon, we had a bill passed during the 2021 legislative session that is about providing palliative care in a person's place of residence. So this is kind of a complicated slide. It's really more for you to look at later. The bill on the left in the US Congress has not passed yet, but we are hopeful it will pass. The bill on the right did pass in Oregon, and the next step is really going to be a rulemaking procedure with the Oregon Health Authority. And again, this is a busy slide. I just provided it more for background information. There will have to be rules developed if the federal bill passes on the left as well. So anytime legislation passes, then there are rules to figure out what are the details, who's going to be eligible, and how long can they receive the care, etc. So going back to the questions I asked about my pie in the sky idea, if the bill passes and Medicare creates this community-based palliative care project, that would make it a defined Medicare benefit as a program, palliative care. Now it's sort of, in any other type of care, but it could become a defined Medicare benefit, could be provided in your place of residence. We don't know if it would be easy to qualify to receive. Somebody would coordinate it, and you would presumably get the right folks to meet your needs, and they would make regular visits. We don't know how long it would last. You would get to participate in making the plan, and it would be licensed and rate certified under Medicare. And it presumably would be covered by Medicare or insurance, and we hope 100%. We don't know that part. And there's lots of things still to be determined, as I mentioned, what the eligibility criteria would be and how long it will last. But I think there is a very bright future ahead for community-based palliative care. And I would be able to go back to the woman who called me from Eastern Oregon and say, oh, here, call this healthcare provider. They provide community-based palliative care, and they can see if you're eligible. So this is my reference slide. And this is, again, my bright future slide, because I have a great deal of optimism, just as I did when I got my first vaccination back in April. And as of next month, I'll be eligible to get the booster shot too. So anyway, that's the end of my slides. I'll stop sharing the screen and turn it back over to Marilyn or whoever is going to manage the questions, if there are any, sorry.
I believe we have a number of questions.
Okay, good.
Hopefully
I can answer them.
Yeah. Would one of our moderators like to bring Barb up to date?
I am not seeing the questions on my screen, so maybe I need to update my panel. So give me just a second and see if I can do that.
While you're waiting, Tom, I can see the panel, so I'll go ahead and ask the question if that's okay. The question is, I am very interested in how space and environment, from the colors on a wall to music, flyers, scents, can influence and impact the palliative experience, and how we can do better in this capacity.
Absolutely. I mean, that's all of those things can impact the quality of our life and our palliative care. I actually gave a different presentation last year about that advanced care planning, and sort of developing your end-of-life care plan should also include, for your family and friends and caregivers, what music you like to listen to, if there are certain colors you want to have in your environment. if you want to be outdoors, you know, there's a lot of those aspects that can influence our quality of life. And you're right. And I think we need more research and more support for looking at all aspects of our environment.
Thank you. The other question was if more, I think, related to the family of people who are in hospice care. Do they get any support with palliative care? I know it's about the patient, but as far as how to handle the letting go and the patient, how to take, you know, how to take care of themselves when the patient is gone.
Yes, absolutely. So that's a great question, and something we should pay attention to as the palliative care benefit is defined through rulemaking over the next year or so. So in hospice care, the patient and the family are considered the unit of care, and there is a bereavement coordinator and bereavement care provided during hospice care. But, you know, that's such a great question, because in palliative care benefit discussions, I don't think we have talked about counseling and bereavement care and spiritual care for the caregivers as well as for the person receiving palliative care. So that's a great point. I appreciate that being pointed out. I hope to participate in the rulemaking for in Oregon for House Bill 2981 as we define what the benefit is for, and in Oregon, that is going to be initially a Medicaid benefit for people who receive care through CCOs. And that, which is about 90% of patients in Oregon who are receiving Medicaid services. So I appreciate that question.
Barb, I have a question that circles back around to one of your slides. For many of our attendees are living in the Lynn Benton area.
Yes.
If they wanted to reach out to resources in real time, finding palliative care services, could you give us 2 or 3 suggestions on who they might make their first contact with?
Sure. So the first contact should be with their primary care provider, because they may know of who in their community is providing palliative care and could make a referral if that's needed. And my state association has a Find a Provider link on our website. So it's the Oregon Hospice Association, or OregonHospice.org. And I can put that in the chat box. We, on our homepage of our website, up at the top, we have a Find a Provider link. And if you put in your city or your county, it will show you who the hospice and palliative care providers are who have identified themselves to us. So I'm not claiming it's an all, you know, it's a complete list, but it's everybody who's indicated to us that they would like to be listed as a provider. And many hospice programs also have a palliative care branch, and some home health programs have a palliative care branch. So you could call any hospice that you know of in your community, and if you can't find one, then I encourage you to look on our website. We also have a contact us link on our website, or you could email. My email address is on the last slide. I'd be happy to try to point you in the right direction.
Very good. We also had one of our viewers ask if you could put up your next to last slide.
Oh, the references one? Sure, let me go back to that. And, oh, sorry, go down here. I think it was my references slide, this one. And let me say from current slide. Oh, nope, let's see, that's not it. Okay, I gotta go back. Previous, and previous. That's the second to last one. Is that the one you think that was requested?
That's the one that the participant would like to see. So
Sure. Yeah, some of those links are long. So that's why if anybody wants a copy of my slides, I think the Grace Center will be happy to send out the PDF version. And then once you open that on a computer, you can click on the link.
And I think there's a way you can do a screenshot, depending on what kind of computer you have on
Oh,
that. So, but I don't know
yeah.
what it is.
I'll defer that to our tech support person, Ryan, and see if he knows if people can do a print screen as usually at the top of your keyboard. I don't know how it works on a smartphone.
Right.
And I think this is being recorded and it will be sent to all the attendees. So
Oh, okay,
they'll still
good.
be able to get this.
Yeah, great, thank you. Any other questions?
I don't see any at the moment. So
Okay.
questions are.
Okay, well, if we're at the end of the questions, first of all, I want to thank you, Barb, for your informative presentation. But I'm going to turn it over before we start talking about what we're going to do next and taking a break. I'm going to turn it over to Sunita, who's been monitoring the donations coming in. Sunita, did you have some comments?
Yeah, thank you so much. Thank you so much for your donations and thank you for being here today. We have 4 anonymous donors who will each match up to $1,000. So right now we're about $500. We would love to make that $1,000. Your money would be so 4 times more, and this would help Grace Center to help people who need to socialize or come just to be there for the daycare center, to enjoy what we have there. In fact, you can come and visit. We have tours there. Denise just said we offer tours, and Denise is the contact person. So come and see for yourself what it's like. It is an amazing institution, and you'll see how much there is to do for people who use the Grace Center. And also, it does give respite to caregivers. So please, please, please help us make another $500. Your money would, as I say, grow 4 times as much, and it would help Grace Center do so much. So we have another hour or so. Let's see if we can do this. And thank you, thank you, thank you so much for being here. And I will hand it back to Marilyn.
Yes. Yeah, thank you. That's good news to hear about the matches. But now we will take a 10-minute break, and that will put us back to start with our next presentation, which will be a panel presentation on considerations for aging in place. So why don't we meet back at about a little after 20 after 11. Hello, everyone. Welcome back. We will now be starting our final presentation for today. But before we do, I would like to just bring you up to date and reiterate what Sunita Vasquez had announced before the break, is that we've been getting during the course of the morning a number of anonymous donors who have offered to match donations up to $1,000. So we really encourage you to make some donations and help us take advantage of all our matches. So today, going on to the presentation, today's presentation is going to be a panel presentation, and it will be on considerations for aging in place. Our panel speakers include Alicia Lucky, who is the program manager at Oregon Cascades West Council of Governments. It also includes Angie Sagenthaler, who is a Peerless mental health case manager, also at Oregon Cascades West Council of Governments. And finally, we have Melissa Cannon, who is an associate professor of gerontology at Western Oregon University. Like our prior presentations, each of our panel members will be answering questions at the end of each of their presentations. So don't forget to use the Q&A tab on your screen to post any questions you have as the program progresses. So please welcome our panel presenters. We will begin with Alicia.
Great, thank you so much. Can everybody hear me okay?
I can.
Okay, great. Well, thank you so much for having me here this sunny afternoon. This is beautiful weather we're having. And I'm just so pleased to be able to do this with all of you. I am Alicia Lucky, and I'm the Community Services Program Manager at the very long name Oregon Cascades West Council of Governments. And my colleague Angie will chat here after me. And we are really here today to let you know what can we offer. A lot of you might know us as a local senior and disability services. What is it that we can offer you to help you age in place with our programming and also through our connection with community services. And so I will start by saying that in Senior and Disability Services, we're the local area agency on aging, the COG. And that's a fancy way of saying that we're a Type B transfer agency that case manages all Medicaid and SNAP for Lynn, Benton, and Lincoln counties in-house. And so as you can imagine, managing Medicaid and SNAP is a big old chunk of what we do. But today we're going to talk about what else is it that we do. And for me, it's the more fun stuff. And so when we can connect with people in their homes, bring hot, nutritious meals to their homes, connect volunteers, create organic relationships. And so that's what I'm here to talk about. So what I wanted to do here is talk a little bit about what we have at the COG. I think sometimes in these presentations, we throw a lot of information at you, and by Monday you think, now where do I go again for this? So I just wanted to share my screen real quick and just bring you to our main website. Make sure you can see it. Is everybody seeing that main website? Great. Okay, so this is the website for the Oregon Cascades West Council of Governments. We're essentially an intergovernmental entity, and we work on behalf of the different governments in our 3 counties. So on behalf of the city of Corvallis, Yachats, in Eastland, out in Lebanon, and we can manage contracts and do a whole bunch of fun stuff. So if you start here at our page, you might be overwhelmed as you kind of look and say, well, where do I go to get what? Well, you're going to click right here on this home where it says Community Services. And I'm going to kind of go through some of the things that you can have with us. So the first thing we're going to look at, if you see this letter right, this first thing right here is Benton County Veteran Services. So the Council of Governments serves as the local veteran service office for Benton County. And I know a lot of you are from Benton County. So if you click on it here, you'll see all the numbers that you can call. We recently just moved. We're really excited. We're right by Five Guys now. We're in the complex kind of by Samaritan Medical Services back in there, and that's where your local veteran service office is. So if you're a veteran or you're caring for a veteran or your neighbor's a veteran and they need supports, please come and check us out. And so what they can do is help you with claims with the VA, help you navigate that process. That office is also our local office for Corvallis residents that need help with senior services. And so that is one resource for you. Meals on Wheels is a more well-known entity, and my friend Angie that's going to jump on here is going to chat through Meals on Wheels with you. The next thing I'd like to chat about is this next tab, which is the money management program. And right here, you'll see the name of the coordinator. Her name is Ashley, and she's lovely. Former administrator at a memory care facility here in town. And essentially what the money management program does is provide assistance with personal money management. And so, many times if we have folks aging in place, if they start to get confused about when bills are due or what to do with that, a volunteer can come and help you, usually about one time a week or one time a month when you pay your bills, and help you navigate how to do bill pay, how to kind of get all of your checkbooks in order. This is highly vetted, as you can imagine, with lots of checks and balances and monthly audits. And it's a contract that we have with DHS. The Oregon Money Management Program is run throughout the entire state of Oregon. And so we administer that in Lynn, Benton, and Lincoln counties. If we get to a point with folks where they need more than the simple bill pay services, then you'll see here that we can also be a representative payee for you as well, and help manage your finances. And so the eligibility for this is 60 years of age or older. You have to live in a program service area, and so that's Lynn, Benton, or Lincoln counties, and typically limited income and assets, and it depends on folks in the house. So, and I'm going to open this up. I want to leave lots of time for questions for you. So I'm going to kind of go through this quickly. The next one is the Retired and Senior Volunteer Program. This is national service. If you've heard of AmeriCorps, we are AmeriCorps seniors. And so what we do is recruit local volunteers 55 and older to kind of serve gaps in the community. And so one of the programs that we do through RSVP, and you'll see my contact information here. This is the main line to our number, this 0849, or you can email me here at alucky, and I'll put it in the chat here in a second. But one of the programs that we're most known for is right here is our Sheba program. And so our wonderful presenter that just talked about, yikes, I'm soon to be 65 and all of a sudden my mailbox is exploding. My mom in Michigan just told me the same thing. She said, do you know anything about this? I said, Mom, I run a Sheba contract. Yes, I know about this. So if you are 65 or have a disability and you are getting on Medicare, Sheba is a great place to start. It stands for Senior Health Insurance Benefits Assistance, and it's trained volunteers that they have to become accredited. There's different modules that they learn. Medicare rules and jargon are forever changing. And I think I saw Jan Molnar Fitzgerald on the participant list. She's actually a Sheba volunteer out in Lincoln County. And these are trained, credentialed volunteers to help you navigate. What does it mean to have a Medigap versus an Advantage plan? My meds just changed in the last year. Where do I put that in the Medicare.gov website? They can help you navigate that. Right now in Benton County, we are just doing phone appointments during COVID, but we can arrange that for you. We just started on Wednesdays doing distance, safe, masked, in-person appointments again at the new community center. And so I highly encourage you, whether you're new to Medicare or you've had it and you're not sure about your plan. Right now we're coming up on, as you know, the annual enrollment period, and it's from October 15th to December 7th. And I would ask you to make an appointment early, because usually by the end of November, we're kind of full with our counselors. So this would be the number you would call for a Sheba appointment, and they can help you kind of navigate that. Along those same lines, we also learned with our Medicare counseling that we like to say that Medicare stops at the bathroom door. So it does not cover durable medical equipment that you find in the potty, right? We have raised toilet seats and grab bars, maybe a transfer bench or a shower chair, maybe a special kind of grab bar that somebody's recommended for you. So we have written a grant to the Siletz tribe and have been funded almost every year to be able to provide durable medical equipment for Medicare beneficiaries that can't get those sorts of things covered by Medicare. And so I'm happy to announce we just received another award. We have healthy funding at the moment. This is one that does kind of ebb and flow with funding, but the number again is this 812-0849 number, and come talk to us if you need help with different durable medical equipment. The other thing I wanted to chat about here is tax aid. We also help recruit volunteers for local AARP tax aid. I know this past year with COVID, that's kind of a one that was kind of hit or miss. I'm hoping this coming tax season they'll be available. During normal years, though, we are the ones to help train and get volunteers where they need to go in the 3 counties. Okay, and then the other thing I wanted to chat about really quick is our Stand By Me program. So this is a fairly new program, and it actually came to us from Commissioner Zan Ojero, who heard about this program. It's a financial coaching program, free one-on-one, and I like to call it money therapy. It's not going to the bank and getting a brochure and saying, here's how you make a budget, good luck. Or it's not a financial wellness course that you take for 6 weeks, you get on this high, and then your Amazon, you know, whatever you like to buy on Amazon kicks in. This is ongoing coaching for financial wellness, and we serve folks of all ages. And so this program, it's called Stand By Me, is in the entire state of Delaware. It's infiltrated in their business sector and healthcare, and just this wonderful program. The fiduciary is their local United Way. And so the commissioner heard about it and said, hey, we got to get this in Benton County. Provided the commissioners provided seed money for it, and now we're nearing on 3 years of implementing it. Recently just wrote a grant to the Oregon Community Foundation to do some outreach with the Latinx population in this, make sure that all of our resources are colloquially sound. And so it's just really neat. And so if you're interested in that program, here's another number you can call, or you can also call me. Angie, who's about to speak, is actually one of our trained financial coaches. And so this program has four main things we're trying to do. We're trying to build the budget. Nobody likes the B word, but it is what it is, right? We would like to increase our credit score, decrease debt, and increase our savings. And so our financial coaches can help you kind of navigate that. We can meet you via Zoom. We can do it on the phone. And it's just kind of this accountability partner to make sure that you're staying within your means. Or during these bizarre times where there's child tax credits or stimulus payments, you know, is that making me over income for something? Those are sorts of things that you could chat through with your financial coach as well. Okay, and the last thing I wanted to talk about was our Senior Companion Program. I'll exit here. And a Senior Companion Program is a special program that I want to chat about with this group because it's another resource for providing respite. Senior Companions are another AmeriCorps senior program, also housed at the COG. We have all 3 now. We've acquired them over the last few years. And it uses volunteers 55 and older to help other folks age in place. And so I sit right by the Aging and Disability Resource Connection at the building at the COG, and I hear call after call coming in saying, I don't qualify for Ride Line. I don't qualify for Medicaid. I'm on Medicare, but I don't make enough to, you know, receive some supports. I'm not sure what to do. I really just need a volunteer to help, maybe with a quick trip to Winco, or help me with a little bit of bill pay, maybe some light sweeping. And during times of COVID, you know, just a warm reassurance call, a check-in like we all need, right? And so this is I feel like Senior Companions really hit that gap, that sweet spot, and that they aren't quite a home health aide, but they're trained beyond your average neighbor, let's say. And so we have over 22 Senior Companion volunteers in Lynn, Benton, and Lincoln counties. They have received robust training in this day of COVID. They have learned from non-emergency medical transportation providers how to disinfect their car, make sure their passenger stays in the back seat. We've done you know, parades in the COG parking lot where we hand them appropriate PPE. We've really worked hard to keep this thing going during this time, because we know that folks still need to go get their eyes checked and still need to go make sure that they get their prescriptions in a timely way. And Senior Companions have been able to do that. So if you have, you know, a need for companionship is one of our work plans, transportation is one of our work plans, or respite, we are finally to a point where we're we're able to take some more referrals. And so the number for that would be our local ADRC number. And I will have Angie kind of chat about the ADRCs and how to kind of go through that referral process. So that's just a handful of what we're doing at the COG. I am so pleased to be able to kind of be in charge of these smaller funded programs and make sure that they stay here and that we're, you know, stretching our budgets as much as we can to serve as many people. And what we're finding is, you know, the more folks we serve, the more we're learning about other gaps. And so with my grant writing hat on, I've been able to kind of, you know, write more other things that we can do. We are so involved with community partners in all 3 counties. We're able to kind of, you know, share resources. And what we found during COVID and what we found during the fires that affected both our Mill City and Otis folks is that many of the folks that we're serving with these programs, they don't have, you know, a huge social circle, or many times I'm the one listed on their emergency contact list. And so during these times of hardship, it's been really a beautiful thing to see that the volunteer programs have really served as the eyes and the ears of the community for these folks in need. So I will stop there and I can open it up for a few questions.
Alicia, I hope I didn't miss you touching on this, but we do have a question in chat.
Okay.
Will the Oregon Cascades West Council be hosting the Caregiver Appreciation Day in November? I've really enjoyed it and missed attending.
You know, I do not think we are hosting one this year. I can ask Angie if she's on. I don't think we are. I think the past year, because of COVID precautions, I think we did more sending out of items to the folks' homes, but I'm not sure. Ange, do you know?
Yeah, Alicia, that's correct. So because of COVID and the concerns with that, again, I don't think we're going to be able to host that. We definitely miss it, but yeah, I think we're going to have to skip that this year again.
Hopefully next year. COVID's put a damper on a lot of these fun things, hasn't it?
Definitely.
And that was the only question that I found in chat, Alicia.
Okay. Okay. Well, I'll go ahead and put the website again in the chat, as well as my contact information. I'd love to serve as a resource for any of you. I think sometimes it can be you know, overwhelming when you hear about all we offer and you think, oh, I don't want to stand on the phone and how, do I even qualify? I would really love to be a point of contact for you to help you navigate those things. So
one quick note, Alicia, it just came in on chat. It says a big shout out to Sheba. As a pharmacist, I've been directing folks to an impartial, well-informed resource to help them navigate Medicare. Thank you so much.
Yes, no, thank you. Thank you. I like to say it's our gold star. It's our gold star program. And, you know, we are so blessed to be housed where we are, right? And we have a bunch of retired pharmacists. So when you retire, or even with our proximity to the university, we have a lot of folks in the healthcare industry that once they're ready to retire, this is a great way to keep their mind sharp. I go to these Sheba trainings and they like to navigate and they've got their spreadsheets and they really get into it, you know, and I say it takes a special person to just love the jargon of Medicare, but our folks do. And I would say our Benton County cohort in particular is quite the brainy bunch, and they like to counsel in pairs. We have an awesome group in Lynn County, and typically also offer the training and the navigating at the Veterans Home in Lebanon. And then in Lincoln County, this is a small but mighty group. If Jan's still on, their numbers are almost the same as the other 2 counties, and they do it with about half the counselors. So yes, thank you. It's an awesome group.
We had 2 quick more, or 3 now questions come in real quick here. Do you have any grants for community housing?
Community housing? No, I do not. So another section for the COG is I'm here with bent more towards senior and disability services and our senior serving community organizations. But another leg of the cog is community and economic development. So housing and that sort of stuff would likely bend more to that department. Our new director, in fact, Jenny Glass, comes from a housing background up in Portland and just started within the last year. And so I'd love to connect you if you have any questions for her. Shoot me an email.
Super. So also, you mentioned non-medical transportation. How do your services compare to dial-a-bus?
How do they compare to dial-a-bus? So I would say we differ in that we do, I'm not sure if dial-a-bus does this. We're super supportive of dial-a-bus, and a lot of times we're sharing similar clients. But we do have, you know, where a typical senior companion visit, let's say pre-COVID, and even now because they have the PPE in place, is you can go to somebody's house and kind of make sure that, you know, they're turning the oven off and it looks like they didn't forget to check the mail that week, and kind of sit down in the living room with them and chat with them about how the last few weeks have gone, hop in the car and go to Winco. And then if they get there and they're like, you know what, they don't have what I want, I'd really like to stop by real quick at Fred's. And I also forgot I need to get a battery for something. They can go to Freddy's after that. That would be fine. And so it's a little bit more fluid. These folks, we don't serve a ton of people. So, you know, the caseload is only 4 to 5 that we assign each volunteer. I like to call it matchmaking because we really get to know this group of people and we kind of match up similar interests in proximity, so we can kind of stretch out those budget dollars as much as we can. But yeah, I would say the biggest difference is that we have some fluidity, and we have, you know, we can pick up somebody if they just want to go for a walk in the park. It can be a companionship work plan. It doesn't have to be driven by just nutrition or transportation or doctor's appointments, which has been helpful in COVID.
One last comment. Love Inc. provides bathroom equipment, and interfaith caregivers provide various services, including rides.
Yeah, so when we get a DME form, one thing that we'll ask is, have you contacted Love Inc. first? Because we do want to make best use of these dollars, right? And so if there's something that has that's used that can be used again, we typically ask them and send them to those resources first. That's a very good point. Same thing with volunteer caregivers. Actually, in Albany does something similar. They've got a connection with Target and the fire department, and they tend to have depends and grab bars. So we kind of work with those other groups and are aware of each other. So that's a very good point.
Yeah, they indicated these services are free as well.
Mm-hmm. Yep.
One last thing, are there any bill pay services for people such as those living with dementia who don't qualify as low income?
You know, Ange, correct me if I'm wrong. I'm going to pick your brain, my dear. For money management, do they have to be at a certain income status?
I believe. Oh, now you're testing me.
we can get back to you if you'd like on that, and connect you with the gal in charge.
Sorry about that.
That's okay.
I just don't want to give any misinformation.
Yes, no, I agree. So Terry, if you send me an email, I'll put it here in the chat. I will connect you with Ashley on Monday and we'll let you know.
Great. That looks like it for all the questions, Alicia.
Okay, great. Thank you.
Okay, so I guess our next panelist is going to be Angie Siegenthaler, who, as we mentioned earlier, is a PEERS mental health case manager at Oregon Cascades West Council of Governments. So welcome, Angie.
Thank you. And Marilyn, I have to say, good job on the pronunciation of my last name. It's not an easy thing to do.
Sure, like mine.
Yeah. So yeah, I'm Angie Siegenthaler, and I am a case manager with Senior and Disability Services. So I help with the Stand By Me financial coaching program, as Alicia was saying. And then I also do some of the Older Americans Act programs, which include Family Caregiver Support Program, options counseling, we assist with Meals on Wheels, and there's just a kind of a whole host of programs that are more directed at helping people to stay aging in place and those who are not ready to go on Medicaid quite yet. So the first step usually is that you would want to contact the Aging and Disability Resource Connection. I know Alicia touched on that too. And with that, you can call them and they'll just briefly go through, kind of ask some screening questions to see what you're really looking for and what may be the best way to route you. So they're basically almost like the mail room. They can give you some good information and then route you to the right worker. But so then once you get routed to us, we'll start with options counseling and we'll talk about your specific situation and kind of what you're looking for. We can talk about Medicaid with you as well. But the programs that we actually administer in my area are more the non-Medicaid, but we could help refer you to the Medicaid case managers as well. So with the Family Caregiver Support Program that we do, it's for people who are caring for loved ones that are 60 or older and that they're mostly, I believe it technically has to be like providing 3/4 of their care and aren't being paid for it. So with that, a case manager will help set up a supportive plan, basically just to assist the caregiver in getting some access to respite, all kinds of things to just help them as they are helping the person they're caring for. Because we know that that's a very strenuous job, rewarding, but very difficult. So we want to help support them. So we can give small yearly stipends where the caregiver could help bring in someone, say they wanted just 5 hours off so that they could go shopping by themselves or take a nap or whatever it may be that would help them the most. They could use those funds to bring somebody in to help them. With that program also, if that's not necessarily something that someone's looking for, we can also assist with helping with Lifeline. So like the necklaces or the bracelets that you wear that alert, medical attention if something were to happen. Usually it's on those just because it is an Older Americans Act program and the funding kind of comes and goes with that. So we try to be pretty careful. There's also Oregon Project Independence. And so with that program, you have to be 60 or older and you have to have some hands-on care needs. So it could be something like if you have difficulty walking outside or on uneven ground, so you need someone to like put their arm in yours to help kind of steady you and help you get in the car, or just different things like that, maybe help bathing. With that program, someone will assess you and then you can get up to, and this kind of varies too, depending on funding, but it's just about 5 hours a week of help from a caregiver that you can hire to bring in. And then depending on the person that's needing the care, what their finances are, there may be a small pay-in. Typically there's not, but it's a possibility. And this program is really specific because it's for those who don't have high enough care needs, like to need to go to Medicaid, or maybe have too many like financial resources and aren't ready to go to Medicaid that way either. So we want to be that kind of catch-all support program to help provide a little bit of care to help you stay in your home before you have to look into Medicaid or something more like that. We also have Meals on Wheels, which my specific county, I'm working right now with Lincoln County, but we also do Lynn and Benton too. We do the assessments for, so that just needs a phone call and we'll ask some questions. You have to be 60 or older, or if you're Native American, you can be 55 or older. Homebound mostly, or just unable to drive for the most part. The meal amounts depend on the area. So most places are able to do Monday through Friday lunches. And some, so like on the coast, you can get 3 hot meals and 2 frozen ones to cover your Monday through Friday. And it's just a suggested donation, so nobody's obligated to pay. And that referral also would start with the Aging and Disability Resource Connection. And I can put the contact information in the chat to reach them as well. Alicia, are there things that you want me to touch on besides those?
No, I think that's good. Let's stop there and see if anybody's got questions.
Okay.
Okay, we have a question, and basically it's, when is it a benefit to the patient to be removed from their home and transition to their adult child's family home?
I think that each situation is so different and specific. I think if, it has to be the older adult that really has to be kind of making that decision, unless they're at a point where you have to get an attorney to basically have them deemed incompetent to make their own decisions. But really, if they're able to stay in their home and they're able to maybe use some of these services to help them kind of stay in place and do okay, typically that's the best way to go. If they're willing and they would like to move into a family home, then that's great. I mean, and by all means, that's a great way to go as well. I just know that a lot of times, just with people, consumers that I speak with, usually they're really wanting to stay in their home for the most part, as long as they can.
Very good. I have a question, and that is, our first speaker talked about having these conversations with folks who need services, but may not be willing to have that conversation. And there was some talk about having those warm-up conversations first, and finding out who they are, what their situation is, and providing that connection. But then the next step would be to be able to give them something to have in their hand. And I know that in my position, I have a flyer from Sheba that I can say, yeah, I know Medicare is really complex. I know a really good group that's very impartial. Does your organization provide flyers for some of the other services besides Sheba that we could, that people could have on hand for when they have these conversations and say, oh, and by the way, here's the contact. So when they walk away, they don't have to remember, it was this phone number or these people or whatever. Are those resources we can, all of our attendees could have access to be able to hand out?
Yeah, certainly. We have like brochures for each of the programs. So I think that's a great way to start. And, kind of like what you were saying, sometimes that's good as, an initial step to sort of let the person kind of take a look at it and on their own time, maybe warm up to it and then have that information to be able to reach out when they're ready. So yeah, we can definitely get those brochures out.
Okay, so we can contact you through these links that will be shared at the end, and to access those sort of brochures.
Sure, yeah. And I was going to mention too that with these programs, like with the options counseling too, if it's a family member themselves who doesn't know maybe if their loved one is ready or open for care, they can still call us and kind of go through the process to see, you know, what's available and maybe good ways to start those conversations about tapping into care and things like that. So we're happy to talk with friends or family members too, to help guide them along the way.
Very good.
Yep, and I would say my email's in there. If you would like something sent, we could do that. I would say too, just even as staff, we were talking about this the other day, that we find that once someone kind of makes a jump to Meals on Wheels, then they see a volunteer that is consistently there that they can bank on, and they realize like, wow, this is really helpful. I wonder, and it kind of opens up their eyes to other things. So we have seen that. The other thing is in this age that we're in, we were just talking about, how many tabling events have we done? I would say just this month I did Albany Rotary, we've done Corvallis Market, and then the Albany Expo, but that is the most we've done in a year and a half. So typically we're at the senior fair in Lincoln City, we're at all the county fairs. And so that's where we do a bunch of our handing out of brochures and stuff. And so, in this day and age, if you'd like a stack sent to you and you want to kind of hand out, that would be great, because we have been limited a little bit in our outreach in that regard, especially with the group. And I'm the same way. Like, I don't have a Kindle. I want the piece of paper. I want to be able to look at it and highlight it and put it up on my fridge. So.
Good. It looks like at this point, that's the questions we have for now. And we'll turn it on over back to Marilyn.
Yeah. So now we'll move on to our final panelist, which is Melissa Cannon, who's an associate professor of gerontology at Western Oregon University. Melissa, are you here?
Hey, yeah, thank you. Nice to see everyone. And I am going to go ahead and share my screen.
While you're doing that, Melissa, may I please just add that we're just $200 away to make the $1,000 donations, and that will grow 4 times. So please, everybody, thank you for your donations. And we've just got $200 more to go. So thank you so much. Thank you, Melissa.
Absolutely. Well, so these have been great presentations. I really appreciate that there's just so much useful information that was shared. And my presentation is a little bit different, but I guess as the sort of final presentation, it's going to help us kind of zoom out and think more broadly about some considerations as we age in terms of our home and our community and where we are aging in place. So aging in place is a concept that you've been hearing throughout this presentation, and this is a topic that has been researched quite a bit in gerontology. It is essentially the idea that a person can remain in their home and in their community safely and independently for as long as possible. And the reason we talk about aging in place so much is because it is overwhelmingly the preference of individuals. And there's been kind of a shift in the way that we talk about aging in place to really thinking about aging in the right place, right? So there's an emphasis now on trying to help people think about, what ideally is the place where you would want to grow older? What would that look like? And how can you be really planful for that starting from an earlier age, right? There was discussion earlier today about ageism, and that we tend to deny the fact that we're going to get older. We tend not to want to think about what our environment should look like as we are getting older. And so I'm going to talk about some of those considerations that we might want to have as we move through our life course. The fact is we want to have a lot of choice about where and how we age. But again, overwhelmingly, older adults say that they want to stay in their current home and in their current community. They generally, many people are not interested in moving into a long-term care setting or having to leave their home for any other reason, any health-related reason or other reason. People who are a little bit younger, and maybe the kind of mid to later life, also expressed that they want to age in place, but to a lesser degree. So, it's useful to maybe, when you're in that sort of age 50 to 64 range, to be thinking about, if you're going to move during that time, is this going to be the last place perhaps that you want to have to really move to, right? If you're thinking about purchasing a home in your, early 60s, maybe, it's important to think about how much are you going to want to leave that home if it becomes necessary. So, if you think that this is the home in which you want to age in place, you might want to start making those considerations about, what are the things that you want to have there to allow you to do that. As we get older, we spend an increasing proportion of time at home. And when we think about home as, a place in our lives, it's the most intense expression of a relationship that we can have with place. And there's a number of reasons for that, right? Home has all kinds of really important dimensions. It's where we feel centered. There's a sense of permanence, ownership. We feel safe in our homes. We feel that we have privacy. We can relax. We can express ourselves. And also home gives us a sense of responsibility. We have to maintain our homes, and that can be really important in terms of, having a sense of purpose, making sure that you're tending to the yard and keeping your home sort of maintained. So these are really important dimensions, and also where people spend time in their homes, where they consider the place where they feel the most relaxed and safe, and really what really makes their home environment. Sometimes is just even a single room of their home, or even a single area of a room. So like the person in this picture here, it may be really just kind of an area of the room where they spend most of their time. And the reason that's important to think about is, if you are going to have to move, so, if this woman was in a place where, she suddenly could not be independent in her home anymore, and needed to move into an assisted living facility, that is going to be a significantly stressful situation, right? It's going to be hard to kind of recreate this environment that makes us feel so comfortable and safe. We move, typically about 10 times during our lifetime here in the United States. So, that's, fairly frequent, but, when we reach older adulthood, again, relocation is maybe not something that we necessarily want to do. It's maybe something that we have to do because our homes are no longer suitable for us to live in. And as I said, relocation is associated with significant stress when we are older. And part of the reason for that, as I just mentioned, is, we don't just move ourselves into a new place, right? We move all these aspects of being in place, having, what feels like our home. So arranging the furniture in a certain way, you noticed in that picture that, she had a lot of photos of family behind her. So trying to recreate that situation with all those dimensions that I talked about is significantly stressful, and, not something that we typically prefer to do as we get older. So all that being said, what are some of the things that we might think about, earlier on, so that we can prepare ourselves for aging in place? And in gerontology, we oftentimes use what's called the biopsychosocial framework. So you kind of can think about things from the biological or physical dimension, the psychological or emotional sorts of issues that are part of this framework, and then social issues. So I'm just going to kind of briefly touch on each of these dimensions and talk about what are some of the issues related to each dimension that are useful to think about as we are as we are aging in place, or preparing to age in place. So the physical considerations are those ones that are, really the most tangible. The size of your home. A lot of times when people end up having to move or deciding to move, it's because the size of their home is no longer suitable for their needs. And that usually means that they need to downsize. It's too much house for 1 or 2 people. So the size is really important. Floor plan is also something that should really be considered. So this kind of ties into accessibility, right? Is your home set up in a way that you can navigate easily if you are going to have mobility devices, right? And so if it's not set up that way, what's the potential for modifying your home? What's the potential for adding grab bars or adding a ramp or other kinds of things that are going to be needed if you are going to need to age in place? Obviously, the maintenance needs and the housing conditions are another consideration. For older adults, the median year that a house was built is 1962. And so, there are probably going to be a lot of maintenance needs, depending on the kind of home that you're living in. But for a, kind of single family detached house that was built around that time, there's going to be a significant amount of work that needs to be done. Climate also becomes a consideration, right? So we know a lot of older people tend to retire to warmer places, right? We can get to a point where, we just can't take the long rainy winters, or, if you're somewhere where it snows a lot, or you just don't get a lot of sun, there's a lot of reasons to be thinking about the climate. Transportation, and this ties into a couple different categories, but, where your home is located, if you're living in a suburban area, that's going to be really challenging if you get to a point where you can no longer drive, which is a very real reality for a lot of people. So how close is it to things that you can walk to transit, all these great services that you've been hearing about through our area agencies on aging? Do you have services available around you that you can access? Those healthcare and wellness services, things like that. So those are kind of some physical considerations, some things that can affect you. And again, you kind of have to weigh all of these things against each other, right? So the psychological considerations are things like, what are the kind of memories that you associate with the place where you're aging? Are they more positive, or, do you have a lot of negative memories? How much, how really attached do you feel to that home? The emotional investment or the emotional attachment. Most older people do say that their home's emotional value is more important to them than their monetary value. So, if your emotional attachment to your home is so strong that, some of those physical considerations are just not going to sway you. Again, you kind of have to balance these different considerations. On the other hand, if you're a person who's kind of moved around in your life a lot and you're not very emotionally attached to your home, it might be a little bit easier to consider relocating in that sense. How much, is your home part of your sense of identity? For some people, you might be living in a house that has been in the family for generations, and it's very much a part of your identity. So that's something that you have to consider. And this one also ties into the social considerations, but your proximity to loved ones. If you are in a home where you know that your loved ones are just 10 minutes away or 15 minutes away or something like that, that can give you a lot of sort of comfort, right? Psychologically, it can really make you feel better, versus if you know you're going to be moving somewhere and your loved ones are going to be much further away. All right, and then the social considerations. For some people, having a place where they can host is important. There's a term called visitability, which is the idea that your home is accessible to anybody, regardless of their needs. So if they can come in and use the kind of main area and access the bathroom, that's considered visitable. And so if your home is accessible to allow people to do that, that might be something that you really want to consider. If a lot of your family or friends, if you know that there are people who are going to need accessibility, that can be something to consider. Obviously, your proximity to friends and loved ones is really important. That's, social isolation was discussed earlier. And, you know, being able to regularly see people is a really important thing to consider in terms of where you live. You know, do you have shared space? Do you have neighbors? This picture represents what one of the things that I really love to research, which is a third place, the idea that you have somewhere in your community where you can go and kind of meet up with other people and find community. And so, you know, a barber shop or a coffee shop or a library or wherever it is that you kind of regularly meet up with people, that can be really important. How you want to spend your retirement years. You know, you want to kind of think about your home in that sense. You know, is it going to allow you to do those things? And what are, you know, in terms of crime and safety, you know, are those kinds of issues. And then socioeconomic issues as well. You know, this is where we think about things like the cost of living, the, you know, investment that you make in your home. You know, is that something that is going to allow you to retire, those kinds of things. So those are some just really basic, as I said, you know, we're kind of zooming out here and looking at some really broad considerations. And I see that I'm kind of running up on time here, so I'm going to skip a little bit. But another thing I just want to bring up here is the concept of age friendly. You know, if you live in a community that is striving to be age friendly, that can be a really positive thing for where you're aging in place. So age friendly is a movement that we've seen here, actually globally, but here in the United States, we see a lot of communities moving to become more age friendly. And this is a really positive thing. So it's, I'll show you this kind of graphic here. I'm not going to go through them all in detail, but, you know, it's kind of looking at these sorts of domains, the built environment, the service environment, and the social environment, and how many services are available, how many things are available to kind of help you age in place in your community. And right now, there's a really strong momentum. We have a lot of age-friendly cities and communities here in Oregon. You can see on the right that these are the local cities and communities that have joined the AARP network of livable and age-friendly communities. So, it's a good thing to see that, you know, there's a lot of attention being paid to this right now. A lot of communities are doing really great work to, you know, address those domains, like I said, the social, the service, and the built domains to make themselves more age-friendly places to live. So that can be also a really good thing, you know, if you're looking to relocate and, you know, maybe think about a place that's actively wanting to become more age-friendly. So that's all the time I have, and I'm happy to take questions. I will go ahead and stop sharing my slide. That's my email address there. I can put that in the chat as well.
Dr. Cannon, I don't have any questions, but I do have a comment.
Sure.
One comment is because Medicare pays so little, doctors limit how many Medicare they take. So one needs to move to a new community prior to turning 65.
Yes. Yeah, that's very true, right? Yeah, we have a lot of inconsistency around the country in terms of the generosity of certain programs and things like that. So, yeah.
And then there was another comment, bathroom doors tend to be narrower than normal doors, but unfortunately, I don't remember the context in which that comment may have been made.
Yeah, that is probably in terms of, you know, like thinking about making your home accessible. It's a really good point. And I think, you know, ideally, we can really, you know, get builders to start thinking about this proactively in terms of making a home accessible and modifiable from the get-go, so that we're not having to retrofit, we're not having to do these big, you know, modifications like widening doorways, because it can be really, really costly and in some cases not even possible. So.
And one question just did pop up. What can Corvallis actively do to make the AARP livability list?
Yeah, that's a great question. So the AARP livable community, I would say if you go to the website, there are a ton of resources, and I can pull up that website as well. But there are all kinds of resources available on how to get started on kind of doing an age-friendly assessment of your community, and then essentially submitting that to AARP and saying, we are going to join the network and we want to actively commit to becoming an age-friendly community. And I live here in Independence. I'm trying to see if Monmouth and Independence can get going on that as well. Salem was a really great model. Actually the Center 50 Plus in Salem spearheaded that initiative. They did an assessment of Salem and looked at all of the domains of age friendliness in their community. They did a lot of kind of town hall style meetings, panels of experts, and created a whole plan for, moving forward. And so, it's kind of this continuous improvement plan of, assessing, implementing, evaluating, and then, kind of repeating that. And so, but yeah, I can put the AARP website in the chat for you so you can learn more about how to get that started.
Excellent. Well, Dr. Cannon, that's the end of our questions.
Okay, great. Thank you so much.
Okay, well, thank you, Alicia, Angie, and Melissa for your presentation today. It's been very informative. This does conclude our presentations, but I would first like to thank again our other two speakers, Dr. Rapport and Barbara Hansen, for their information and resources they've provided to us today. And I would also like to thank again our sponsors for this year's event, including Citizens Bank, Samaritan Health Services, Good Earth Pest Company, Samaritan Evergreen Hospice, Timber Hill Place, and Town and Country Realty for their contributions, and also Lumina Hospice for their top donor gift basket. And I especially want to thank everyone who's made donations today. Your contributions really greatly help Grace Center in providing the services to this community and the activities that they provide. And again, we're getting very close to meeting our match. So if there's any additional contributions that you can make, we really appreciate it. So thank you. This concludes our Aging Summit for today, and I thank you all for attending.